This is part one of the lecture on the urinary system. The urinary system is the system of the body that's in charge of removing metabolic waste materials, concentrating the urine, and removing foreign substances like toxins and drugs. The urinary system also monitors and maintains the pH of the blood. It consists of two kidneys, whose job is to receive blood and filter it, the ureters, which transmit blood from the kidneys to the urinary bladder, and then the urethra, which transmits the urine from the urinary bladder to the external environment. The two kidneys are the right and the left. They sit in the behind the abdominal cavity, and they produce the urine. They receive blood from the renal arteries, which are branches of the abdominal aorta. The blood enters each kidney, and then the metabolic wastes are removed. The urine is removed and concentrated, and then the blood leaves the kidneys, entering the renal veins, which then both enter the inferior vena cava and then back into the circulatory system. Each kidney is about 12 centimeters long. It is enclosed in a tough capsule, and the kidneys are what are called retroperitoneal, which means they do not exist in the abdominal cavity. They exist behind or posterior to the parietal peritoneum. The left kidney is slightly higher than the right kidney because of the presence of the liver, which actually causes the right kidney to be somewhat inferior to the left. Each kidney is surrounded by a connective tissue and a fatty tissue that insulates the kidney. This is a diagram showing how the kidneys sit in the retroperitoneal space. You can see this is a kidney here, this is a kidney here, and they do not exist in the abdominal cavity, but they exist posterior to the parietal peritoneum near the deep muscles of the back. The kidneys are divided up into several regions. They have a dense fibrous capsule on the outside of the kidney, and then the outermost region of the kidney proper is what's called the cortex, renal cortex, and then the innermost region is called the renal medulla, which is divided into cone-like structures, which are called renal pyramids. The most central portion of the kidney is an open cavity that's called the renal pelvis, which is where the urine, when it's collected, actually collects in there before being transferred down the ureter to the urinary bladder. Several words to describe regions of the kidney. The hilum is the indented region on the medial aspect of the kidney where the renal artery, the renal vein enter and leave, and the ureter leaves and descends down to the bladder. The renal pelvis is, again, an open cavity in the center of the kidney near the hilum. It receives the urine, which is produced and emptied from the renal medulla into what are called minor calyces, which then empty into major calyces, which then empty into the renal pelvis. Again, the renal medulla is the inner region, which is composed of renal pyramids, and the renal cortex is the outermost region. The renal capsule is a tough fibrous capsule that surrounds the kidney. The functional unit of the kidney are structures that are found both in the cortex and the medulla, and they are called the nephron. The nephron is the functional unit of the kidney. On this diagram here, what you see is a hemisected kidney. You see the renal artery entering, shown in dark red, the renal vein leaving, shown in blue. The renal pelvis is in yellow here, as seen here, and then the cortex being in this region here, inside the fibrous capsule, and then these are the pyramidal-shaped renal pyramids. Each renal pyramid is going to open up into a minor calyx, the minor calyces collect together into a major calyx, and then the major calyces collect together into the renal pelvis, which sits in here, and then it empties the urine down the ureter towards the urinary bladder. Looking at it on a more microscopic level from this region here, what we see is the functional unit of the kidney, which consists of nephrons, which begin within the renal cortex and exist mostly within the cortex, but then do have processes that dip down into the renal medulla. These are called the renal loops or loops of Henle, and we'll talk about the structures that are associated with the nephron in a few minutes. Blood flow. Blood flow to the kidneys consists of renal arteries, which are branches of the off the abdominal aorta. There's a right one going to the right kidney, a left one going to the left kidney. The renal arteries then subdivide into what are called segmental and then interlobar arteries, because the kidney is divided up into lobes. And then those interlobar arteries are going to divide into arteries that go along the border between the cortex and the medulla, called arcuate or arciform arteries. And from these arcuate or arciform arteries, cortical radiate or interlobular arteries extend up into the cortex, off of which come the first vessels of the nephron, called the afferent arterioles. The afferent arterioles enters the nephron, brings the blood into these nephrons. The nephron begins at a capillary bed called the glomerulus. The glomerulus is a capillary bed that begins that is present at the beginning of the nephron. The glomerulus then gives rise to an efferent arteriole. This is a case where you have now a capillary bed followed by another arteriole instead of followed by a venule. This efferent arteriole is then going to lead into peritubular capillaries, which are going to surround the rest of the nephron. They are then going to collect into cortical radiate or interlobular veins, which are going to collect into arcuate or arciform veins, ultimately into interlobar veins, and then ultimately into the renal vein, which is then going to leave the kidney. Shown here on this diagram, what we have is the renal artery entering here. It branches into interlobar, segmental and interlobar arteries, which is ultimately going to give rise to these vessels across the border between the cortex, which is here, and the medulla, which is here. These are called arcuate arteries. And then from these arcuate arteries, interlobular or cortical radiate arteries ascend and bring the blood up into the cortex, and then coming off of these are the afferent arterioles, which then enter the glomeruli or the glomerular capillaries, which are shown in these circular dark red structures here. The urine ultimately is going to collect into interlobular or cortical artery cortical radiate veins, which are then going to collect into arcuate veins, which go on the border between the cortex and medulla, ultimately emptying into interlobar veins and collecting with the other interlobar veins to form the renal vein, which is then going to enter the inferior vena cava. Another diagram showing the same thing. Here's the renal artery entering the kidney, giving rise to the segmental arteries and ultimately the interlobar arteries, which are going to give rise to the arcuate arteries, which go between the cortex, which is here, and the medulla here, which are going to then give rise to the cortical radiate or interlobular arteries, which are ultimately going to give rise to the glomeruli, which are not shown on this picture. After going through the small vessels of the nephron, the interlobular or cortical veins, radiate veins, are going to collect that blood, which are going to empty into arcuate veins, which are going to collect into interlobar veins, which are going to ultimately collect into the renal vein, which is going to enter the inferior vena cava. The glomeruli, which are at the end of the afferent arterioles, are a dense network of capillaries that are found within a cup-like structure called the glomerular capsule or Bowman's capsule. Blood enters the glomeruli through the afferent arteriole, and it leaves the glomerular capillaries through an efferent arteriole, where it enters another capillary bed called the peritubular capillaries. This is a diagram showing the blood flow through the kidney from the renal arteries to the renal veins, as I've just talked about. The rest of the nephron consists of a tubular system that begins at what's called the glomerular capsule or Bowman's capsule, which is a cup-like structure that surrounds the glomerulus. Here's a cortical radiate artery with its afferent arteriole entering the glomerular capillary bed, leaving as the efferent arteriole, which then surrounds the rest of the tubulars as this peritubular capillary system. Surrounding this glomerular capillary bed is what's called the glomerular capsule or Bowman's capsule. Bowman's capsule is the site of filtration of the first step in kidney function. Substances are filtered from the glomerular capillaries into Bowman's capsule. Bowman's capsule then receives the filtered substances from the glomerulus, and then it transfers them through a series of tubules. The first tubule being what's called the proximal tubule or the proximal convoluted tubule. The next tubule being the nephron loop or the loop of Henle, which in many cases dips down into the medulla of the kidney, then rising back up into the cortex, where you end up with a distal convoluted tubule, which then is going to empty into a collecting duct, which is then going to empty down through the medulla again and into an inferior, minor calyx of the in the renal medulla. This is a diagram showing a close-up of the afferent arteriole bringing blood into the glomerular capillary bed. And then the efferent arteriole coming out. This is the glomerular capsule or Bowman's capsule. It consists of two layers of cells, an outer layer of squamous cells called the parietal layer of Bowman's capsule, and an inner layer of cells that are tightly affixed to the capillaries, endothelial cells themselves. And that is what's called the visceral layer of the glomerular capsule. And it's made up of specialized cells that are called podocytes. Podocytes are the cells, as seen here, that basically surround or cover the capillaries in the glomerular capillaries within the Bowman's capsule. So Bowman's capsule consists of two layers, a parietal layer on the outside and a visceral layer of podocytes on the inside. And these podocytes have processes coming from their cell bodies. These processes are called primary processes. The primary processes are connected by what are called pedicels, as shown here, to form these slit-like openings called slit pores that only allow certain things of certain size through. So these podocytes have the ability to allow certain things in and out of the capillary into Bowman's capsule depending on the size of them. And these podocyte slit pores can be increased or decreased depending on the needs of the body at that time. So basically, the structure of a nephron consists of a glomerular capsule, or Bowman's capsule, which then leads into what's called a proximal convoluted tubule, which exists in the cortex of the kidney, then a loop of Henle, or nephron loop, which has a descending limb which descends down into the medulla of the kidney, and then an ascending limb which ascends back up out of the medulla of the kidney, back into the cortex, and then a distal convoluted tubule, which is then ultimately going to empty into a collecting duct, which is then going to also go down through the medulla of the kidney, but it is then going to open up into a minor calyx, and anything leaving the collecting duct entering the minor calyx is what we know of as urine. Another diagram showing the same thing. Here's the glomerular capillary bed. Here's the afferent arteriole bringing blood in. Here's the efferent arteriole bringing blood out. This is the glomerular capsule with its parietal and visceral layer, which would be tightly opposed to these capillaries, leading into the proximal convoluted tubule, then the descending limb of the nephron loop, or the loop of Henle, then the ascending limb of the loop of Henle leading up from the medulla into the cortex again, and then emptying into a collecting duct, which then goes down through the medulla of the kidney and ultimately releasing into a minor calyx. And this shows how the efferent arteriole, when it comes out of the glomerular capillary bed, then splits up into what are called peritubular capillaries, which surround both the proximal distal convoluted tubules, the collecting duct, and the loop of Henle. The specialized capillaries surrounding the loop of Henle are called the vasa recta. And we'll talk about the importance of that and why those help create an environment to concentrate the urine in the next half of this talk. Microscopically, what you look at when you see the cortex of the kidney is you see these roundish structures. These are glomerular capillary beds. The clear area are the Bowman's capsules, or the glomerular capsule, and the thin cells on the outside is that parietal layer of the glomerular capsule. The podocytes, or the visceral layer, are tightly opposed to the capillaries in here. So that's what you're seeing here. Otherwise, you see these tubular structures. These are proximal tubules and distal convoluted tubules that all exist in the cortex of the kidney. In the renal medulla, you have a different situation. You have basically long cords of cells. These are collecting ducts that are bringing fluids from the distal tubule down towards the minor calyx. You also have descending and ascending loops of Henle, and you also have capillary beds of that peritubular capillary system in the medulla called the vasa recta. And this again describes the flow of fluid through the nephron. The nephrons can consist of two different types. Most of the nephrons are what are called cortical nephrons. Cortical nephrons sit near the outer aspect of the cortex, and their loops of Henle, or their nephron loops, only dip a little bit into the medulla. Most of your nephrons are cortical nephrons, but a small percentage of your nephrons are what are called juxtamedullary nephrons. Juxta meaning close to, medullary meaning the medulla. That means that those glomeruli, instead of sitting up near the fibrous capsule, sit near the border between the cortex and the medulla. Those still have their proximal tubule in the cortex, but their nephron loop, or loop of Henle, dips deep down into the medulla and then comes back up into the cortex for the distal tubule and then ultimately the collecting duct. These are going to be important in creating an environment of increased osmotic pressure as you go deeper in the medulla towards the opening of these collecting ducts into the minor calyx. The juxtaglomerular apparatus is a structure that is associated with both the afferent arteriole and a region of the collecting duct made up of specialized cells called the macula densa. These cells are found in the ascending limb of the nephron loop, where it comes right next to the afferent arteriole, and they sense the concentration and the volume of fluid within the distal convoluted tubule. If that flow decreases, such as someone who is, say, dehydrated and not making as much urine, they can signal these juxtaglomerular cells to produce a hormone called renin. This is a diagram of how that works. If you look at how the nephron is arranged, here's the glomerular capsule, here's the afferent arteriole, here's the efferent arteriole. The afferent arteriole going in, the efferent arteriole coming out. This is the glomerular capsule or Bowman's capsule, proximal convoluted tubule, descending nephron loop, and then the ascending nephron loop comes up very close to where the afferent arteriole comes in. And if we look close up at this area, what we see is here's the afferent arteriole bringing blood into the glomerular capillaries surrounded by their podocytes. Here's the efferent arteriole coming out. And this is the distal tubule here with these specialized macula densa cells that monitor the flow in that distal tubule. And they communicate with specialized smooth muscle cells surrounding the afferent arteriole. Those smooth muscle cells, because remember, arterioles have smooth muscle around them, are called juxtaglomerular cells. And the juxtaglomerular cells can be stimulated in cases of particularly dehydration to produce a hormone, and that hormone is called renin. Renin is a hormone produced by the juxtaglomerular cells with input from the macula densa cells in conditions where blood pressure is low or dehydration is occurring. So together, the macula densa cells of the distal tubule and the juxtaglomerular cells of the afferent arteriole make up what's called the juxtaglomerular apparatus, and they're responsible for the secretion of a hormone into the bloodstream called renin. The nephron function consists of 4 processes that occur. The first process occurs in the glomerulus, and that's called glomerular filtration. It is basically simply filtering small things that can fit out of the capillaries and through the podocyte slit processes and into the glomerular capsule. The second process is reabsorption. That's taking things that you have filtered out into the nephron capsule and taking them back into the bloodstream. The third is secretion, which is taking things that were not filtered into the glomerular capsule and pumping them into the tubules of the nephron. And then the fourth is concentration, which occurs as the fluid goes down through the collecting duct through an environment of very high osmotic pressure. Again, if we think about the glomerular capillaries like a hose, and you have fluid coming in through the hose through the afferent arteriole, fluid coming out of the hose through the efferent arteriole. And if you poke holes in that hose, as the fluid goes through there, some of that fluid is going to leak out. Well, that's exactly what happens in Bowman's capsules. Basically, due to hydrostatic pressure on the wall of those capillaries and the fact that those capillaries have larger openings between the cells, substances can leak out of those capillaries and into the glomerular capsule or Bowman's capsule. What can come out? Small things. Things that are uncharged, or things that can be charged, like ions can also come out. But what can't come out? Big things like cells. Cells can't come out. So red blood cells normally can't fit out. White blood cells normally can't fit out. Proteins normally can't fit out, which is why normally in the blood you don't see red blood cells, white blood cells, or proteins normally in the bloodstream. In the urine. The filtered fluid then that's filtered into the nephron capsule is transferred through the proximal tubule and the distal tubule. And some of the stuff that's filtered in, you're going to want back. So you'll reabsorb that. What are you going to reabsorb? Well, most of the water, as we'll see, you'll want to reabsorb. You'll also want to reabsorb nutrients like glucose, amino acids, things like that. But then there's some things that are maybe filtered out, but some of it still ends up in the peritubular capillaries. You want to get rid of that. Tubular secretion pumps those things into the tubules so that you can increase the release of those in the urine higher than what would be normally filtered out in the glomerular capsule. So the first step is filtration. Filtration occurs through the capillaries of the glomerulus and through the podocytes which sit on the surface of those. Small things like water, small dissolved molecules, nutrients, small charged particles, sodium, potassium, things like that can get through. What can't get through? Large proteins. What can't get through? Cells can't get through. Red blood cells, white blood cells, platelets can't get through. The glomerular capillaries are leakier than systemic capillaries. In other words, between those endothelial cells, there are openings in the walls called fenestrae that allow small things through. But again, nothing as big as a cell can get through. What does get through forms what's called the glomerular filtrate. The filtrate is what is small enough to pass through the fenestrae of the capillary walls and the slit processes of the podocytes and end up in the glomerular capsule. Again, here's the afferent arteria bringing fluid in. Here's the glomerular capillaries surrounded by their podocytes with the slit processes. And basically what happens on a microscopic level is those endothelial cells that make up the capillaries have between the cells these fenestrated openings, and then the podocytes on the outside have those slit processes so that substances in the capillary can be forced out those openings and into the glomerular capsule, much like if you had a hose with holes in it, things poking out of those holes, water coming out the hose as you run water through the hose. So the first step in kidney function is glomerular filtration. Filtration occurs through small substances leaving the capillaries in the glomerulus through the podocytes and entering the glomerular capsule. The pressure that forces that fluid out is based on the hydrostatic pressure of the blood entering the glomerulus. The afferent arteriole has a higher diameter than the efferent arteriole, which means it delivers more blood per unit volume than the efferent arteriole takes out. So consequently, that increases the pressure. It would be like if you had a hose with holes in it, you turned on the spigot at one end and then you squeezed the other end of the hose, the water would increasingly flow through those holes because you have a larger diameter coming in than you have going out. So the net pressure of filtration is the forces that favor filtration, which is mainly the hydrostatic pressure pushing out, subtracting the forces that oppose filtration. And that's mainly the osmotic pressure of those proteins and cells that cannot get through, that pull water and water-like material back. Also, as fluid enters the glomerular capsule, you can get a hydrostatic pressure in the capsule that can push fluid back. So here is a close-up of a glomerular capillary. These are the endothelial cells. These are the podocyte slit processes. So you have a pressure in that capillary that's forcing fluid out. That's called the glomerular hydrostatic pressure. They have that at 60 millimeters. But then you have an osmotic pressure from the things that can't get out, pulling water back in of about minus 32. And then you have a pressure that the fluid has in the capsule that's pushing back out at it. And that is recorded here at minus 18. And if you take the 60 pressure out, minus the 32 pressure in, minus the 18 pressure in, you end up with a net pressure out of 10 millimeters of mercury. In other words, as long as there's a positive pressure overall coming out, more fluid will come out of the capillary into the nephron capsule or the glomerular capsule, then will go in, and filtration will occur. This is another diagram showing the same thing with a little bit different numbers. Here's the afferent arteriole bringing fluid in with its hydrostatic pressure, which is 55 millimeters of mercury, in this case, pushing out against the inner wall of the capillary. The inner pressures, the hydrostatic pressure of the fluid in the capsule pushing back, they have that at 15. And then the osmotic pressure, which is of the osmotically active particles in the capillary that are pulling fluid back, they have that at 30. If you take 55 minus 15 minus 30, and you end up with, again, a net outward pressure of 10 millimeters of mercury of fluid from the capillary into the glomerular capsule, which leads to the production of what's called the glomerular filtration rate. The filtration rate is proportional to the amount of filtration pressure you have. Normally, for both kidneys, the glomerular filtration rate is about 125 milliliters per minute. That means every minute in your kidneys, you're filtering 125 milliliters of fluid into your nephron capsules. If you multiply that out for a whole day, that means 180 liters of fluid enters the glomerular capsule every day. Much, much more than your body fluids exist, which means that of that fluid that's filtered over an entire day into the glomerular capsule, the vast, vast majority of it, 95%, has to be reabsorbed, because the only urine you're going to make is about 0.6 to 2.5 liters of urine a day. So of the 180 liters of fluid that ends up in the nephron capsule every day, this is all you produce as urine. The rest of that must be reabsorbed. This chart basically shows, this is in the blood, in the plasma. This is in the filtrate. This is what ends up in Bowman's capsule. So you can see that sodium can pass directly through into the glomerular capsule. So the concentration of sodium in the blood, the concentration of sodium in the capsule is the same. But the concentration in the urine is lower, because between here and here, what's happened is you have actually reabsorbed sodium out. So you produce in the urine much less sodium than you filtered out. Looking at glucose as another example, your plasma glucose level, an average, is about 100 milligrams per deciliter. Since glucose can freely pass into the glomerular capsule, the glomerular filtrate also has 100 milligrams per deciliter. So the concentrations are the same, but in the urine, you have normally no glucose, because all of the glucose, which your body is going to use as a fuel source, is reabsorbed in the urine, through the nephron. So none of it is lost in the urine, which is why normally you do not have glucose or amino acids produced in the urine, because all of those that are filtered out into the capsule are reabsorbed through the nephron. Your body controls the glomerular filtration rate to keep it very, very stable at 125 milliliters per minute through a process called autoregulation. Autoregulation basically changes the diameters of the afferent and efferent arterioles to maintain the glomerular filtration rate at a constant amount. This is called autoregulation, and what it does is, if we go back to here and we look at the afferent arteriole coming in, the efferent arteriole going out, if you constrict the afferent arteriole, then you're going to have less flow into here, which will, by definition, decrease your filtration rate, because you're going to have less volume in there, less pressure on the wall. If you constrict the efferent arteriole, That would be like constricting the end of the hose with holes in it, and you would increase filtration pressure. So you would increase glomerular filtration rate. So what happens is by constricting and relaxing the afferent efferent arterioles, you can maintain a constant glomerular filtration rate, which is what the body does through autoregulation. In addition, the sympathetic nervous system helps to do this by also affecting both the afferent and efferent arterioles to maintain a stable and constant filtration rate of 125 milliliters per minute. Also, as we'll talk about in a few minutes, the hormone renin that is produced by the juxtaglomerular cells in response to low blood pressure also helps to increase glomerular filtration and maintain a stable filtration rate. There are also other hormones, including atrial natriuretic peptide and ventricular natriuretic peptide, which are produced, interestingly, by the heart in response to overhydration, to too much water on board, that also affect filtration rate and affect the amount of fluid that is, the amount of urine that is produced to, in this case, decrease over volume of the body with fluid. Glomeruli, like any part of the body, can become inflamed or infected. Glomerulonephritis is a condition of inflammation or infection of the glomeruli. There's two different types of this. There's the acute glomerulonephritis, which is generally a byproduct of some type of an infection, usually an infection due to beta hemolytic strep. Someone will get strep throat, and then shortly thereafter will develop blood in their urine. It's not actually an infection. It's actually a reaction to the body fighting the infection, where antibodies to the strep form complexes with the strep antigens, and those complexes then lodge in the glomerular capillaries and cause blockage of the glomeruli and some problems with kidney function. This is usually fairly self-limited, usually goes away on its own. That's not to be confused with chronic glomerulonephritis, which is a progressive disease due to some type of an insult. This insult could be due to some type of a toxin exposure, could be due to an infection. This actually has more permanent damage to the nephrons. The kidneys don't function well. They don't produce urine that is able to remove toxins and balance electrolytes and water, and can cause a chronic condition that could lead to someone having to have dialysis. This is the pathology of glomerulonephritis. Again, some type of injury to the glomerulus. What you see when the glomeruli are injured is that normally proteins can't get into the glomerular capsule, but if they're damaged, they can. You end up with proteins in the urine or proteinuria. You end up with blood cells getting into the urine or hematuria. Those inflamed glomerular cells block the glomeruli, decreasing the glomerular filtration rate, which causes multiple problems associated with that. On slides, glomerulonephritis, you see the glomeruli, but instead of seeing the just nice podocyte and capillary endothelial cells, you also see these dense scar-like areas of connective tissue laid down in response to that. The renin-angiotensin system. As I said before, renin is a hormone. It's produced by the kidney in response to primarily low blood pressure. It's produced by the juxtaglomerular cells of the specialized smooth muscle cells of the afferent arteriole. And they secrete renin into the bloodstream, and that renin then circles through the bloodstream, where it comes in contact with a substance called angiotensinogen. And remember, I said anything that ends in OGEN is a inactive precursor. Angiotensinogen is an inactive precursor substance that's produced by the liver, and it's floating through your bloodstream right now. And it just minds its business as an inactive substance until it comes across renin. And when it comes across renin, it is then changed into angiotensin 1. Angiotensin 1 is also inactive, largely, until it passes through the bloodstream, through the lungs, where the endothelial cells of the lung capillaries produce another enzyme called angiotensin converting enzyme. Angiotensin converting enzyme then cleaves the angiotensin 1 into angiotensin 2, which is the active form. Angiotensin 2 has many different effects. It is, first of all, the most potent vasoconstrictor in the body. What does that mean? That means it constricts arterioles. Those are your major resistance vessels. It also increases the secretion of another hormone from the adrenal gland called aldosterone. Aldosterone is an adrenal hormone, the adrenal glands being glands sitting on top of the kidneys. Aldosterone actually acts on the kidney to increase water reabsorption, to increase salt reabsorption, and to increase the excretion of potassium in the urine. The water reabsorption and the sodium reabsorption then rehydrates or brings up the blood pressure. Angiotensin 2 also increases the secretion of ADH, or antidiuretic hormone, which is a hormone we'll talk about in the next half. It's produced by the posterior pituitary gland, and it actually acts to concentrate the urine. It acts to allow water to be reabsorbed in the collecting duct, from the collecting duct into the peritubular capillaries, thus allowing less water loss in the urine and increasing blood volume and therefore blood pressure. And it also, angiotensin 2, acts on the thirst center of the brain to increase thirst. This is another diagram showing the renin-angiotensin system. Again, in response to low blood pressure, renin is produced. Renin then enters the bloodstream where it meets up with angiotensinogen, which was produced by the liver, and it cleaves it into angiotensin 1, which then goes to the lungs, comes in contact with angiotensin converting enzyme, causing angiotensin 2 production. Angiotensin 2 being the most potent vasoconstrictor. It constricts arterioles, which increase blood pressure. It also increases thirst. So you increase your fluid intake. This is going to increase your blood pressure. Increasing arterial vasoconstriction going to increase your blood pressure. And also it's going to increase the secretion of antidiuretic hormone, which is also called vasopressin, from the posterior pituitary gland, which is going to cause increased water reabsorption by the kidney tubules, which is going to increase your blood pressure. In addition, angiotensin 2 is going to stimulate the adrenal cortex to release the hormone aldosterone. Aldosterone is going to then stimulate the cells of the distal convoluted tubule and to some extent the collecting duct to increase sodium reabsorption into the peritubular capillaries. Water will follow, and therefore you will increase fluid volume in the blood and you will conserve water and increase your blood pressure. So this is how the renin-angiotensin system works in response to low blood pressure. Once substances are filtered into the nephron, the glomerular capsule or Bowman's capsule, they then enter the proximal convoluted tubule, followed by the descending, then the ascending loops of Henle or the nephron loops, then the distal convoluted tubule. And it's in these tubules in which the processes of reabsorption and secretion occur. Reabsorption is taking of substances that have ended up in the tubular system and pumping them out into the peritubular capillaries. This is stuff that has been filtered into Bowman's capsule that you want back. What do you want back? Well, you want water. Most of your water is going to be reabsorbed. As we said, you filter 180 liters of water into Bowman's capsule every day. You don't want to pee out 180 liters. You in fact want to pee out very small percentage of that, so most of that will be reabsorbed. You also want to reabsorb nutrients, sodium, potassium to some extent, if you need extra potassium. You need to reabsorb glucose, amino acids, things like that. Those are all done through the tubular system through reabsorption. Most of the tubular reabsorption occurs in the proximal tubule. Some of it occurs in the distal tubule. Tubular secretion means substances that were not removed in enough volume in the filtration, and you want to get rid of more of them. That means you're pumping them the opposite direction from the peritubular capillaries and into the proximal or the distal tubular system, where they then are relieved from the body through the urine. Tubular reabsorption can be of many different ways. Active transport is one of the ways in which tubular reabsorption occurs. Many of these occur through the pumping of sodium from the tubular fluid out into the peritubular capillaries. And when sodium is pumped, water tends to follow. Since sodium is a positively charged ion, negatively charged ions follow. Other substances that are actively transported are nutrients like glucose, are pumped out of the tubules because you don't want to lose your glucose. Amino acids, you can use those to make proteins with, so those are all pumped out of the proximal tubule and picked up into the peritubular capillaries. Again, you filter out 180 liters of water every day, but you reabsorb 99% of that, so you only excrete about 1.8 liters of water a day, which is a normal urine output. You filter about 630 grams of sodium in your nephron capsules or your glomerular capsules every day. You reabsorb 99.5% of that, and you excrete about 3.2 grams of sodium a day. The proximal tubule is going to reabsorb about 70% of the sodium and the water. The rest of it is reabsorbed in the distal tubule or in the collecting duct. This is a diagram showing how this works. Basically, when the filtrate enters the proximal tubule, the cells of the proximal tubule actively pump sodium ions from the tubule out, where they're picked up into the peritubular capillaries. When that happens, negatively charged substances like chloride, since you've taken a plus and gone here, the negative charges follow the positive so that you can keep so the chlorides are pulled over. And when you start pulling all these ions over here, water tends to follow. So water follows the salt. So when the sodiums and the chlorides come out of the tubule and into the peritubular capillary, water molecules follow them, and that's how you reabsorb water passively through osmosis. As the osmotic pressure increases here, as you increase ions here, and you decrease ions here. Another diagram showing the same thing. Here's the afferent arteriole coming in, the glomerular capillaries, the efferent arteriole coming out, peritubular capillaries. Here's the proximal tubule pumping sodium ions out. So you're tending pluses out from here to here. The minuses follow the pluses. And here's another phosphate ions follow the pluses going out here. So these are drawn out because you're pumping these sodiums out. These are following passively. These are following passively. Bicarbonates follow passively. And as you move all these ions from here to here, this area gets hyperosmotic compared to this area, so water is pulled by osmosis out of the proximal tubule and into here, and that's how your water is reabsorbed into the peritubular capillaries. Tubular secretion, that's the opposite. Those are all active transport processes that are actually pumping things from the peritubular capillaries and into the distal, usually the distal tubule or the collecting duct. What types of things are secreted? Potassium is actively secreted to maintain potassium levels. Hydrogen ions are secreted, which is one of the ways in which your body balances out the pH or the hydrogen ion concentration of the blood, is by excreting in the urine excess hydrogen ions through secretion to maintain a blood pH that's stable. This is a diagram showing, here's the distal convoluted tubule here, and here's the collecting duct here. This is a peritubular capillary, and what's happening is here you have a system where you're pumping sodium ions out of the distal tubule into the peritubular capillary, and they're being exchanged. So you're having 1 plus go this way, it's exchanged with a potassium coming this way, and so you end up excreting potassium. So potassium excretion in the distal tubule is again based on active pumping of sodium through the wall, and this is in many ways under the direction of the hormone aldosterone that is produced in response to the renin-angiotensin system. Hydrogen ions are also excreted the same way. Remember, we said that what happens in the distal tubule is you pump sodiums out into the peritubular capillaries. When you take a plus this way, they can be exchanged for a plus the other way. It could be a potassium if you have to get rid of excess potassium, or if you, let's say you took a couple of aspirin and aspirin decreases the pH of the blood and you want to balance out that pH, you want to get rid of those excess hydrogen ions in that aspirin, what's going to happen is you will pump sodiums into the peritubular capillaries. They will be exchanged for hydrogen ions, and you will excrete those excess hydrogen ions to maintain a blood pH of 7.4, which is normal. Some drugs are excreted by secretion, penicillin being a classic one. Penicillin, here's penicillin molecules entering the glomerulus through the afferent arteriole. Since penicillin can actively transfer through the glomerular capillaries, some of the penicillin will end up in the glomerular capsule at the same concentration as that will be in the efferent arteriole. This will continue down the proximal tubule, and ultimately the penicillin that is present in the peritubular capillaries will be secreted, will be pumped into the tubular system, so that what is excreted in the urine is not just the penicillin that was produced by filtration, but more, because it'll be also the penicillin that is secreted from the peritubular capillaries which is why penicillin is so aggressively excreted from the body. So, we talked about 3 processes in this video so far. We talked about filtration, which occurs in the glomerular capillaries, where substances that are small enough due to the hydrostatic pressure on the glomerular capillary wall are be pushed into the glomerular capsule. We've talked about reabsorption, which is the return of substances that are filtered into the glomerular capsule and pumped back into the peritubular capillaries: water, glucose, amino acids, things you want back. And we've talked about secretion, which are things that may be filtered into the glomerular capsule, but you want to get rid of more of them. So those that remain in the efferent arteriole and into the peritubular capillaries are actively pumped in, so you end up with an increased removal of substances above what filtration did for you. That's the end of part 1. Make sure you watch the second part, part 2, for the remains of this talk on the urinary system.